Thanks to you and to Vessel Plus for this invitation. As you know, after acute coronary syndrome, it's crucial to act early, to go deeply, and to maintain low LDL cholesterol. The issue for cardiologists that we have discrepancy with differences between guidelines. For example, ESC guidelines advocates a step-by-step approach, whereas European Atherosclerosis Society statement act for an upfront strategy. What does it mean, upfront strategy? It means to associate early during hospitalization, high-intensity statins and ezetimibe before discharge, and after to check at 1 month, and to implement PCSK9 inhibitor for patients which LDL cholesterol is above 70 milligram per deciliter. It represents about 10 to 15% of acute coronary syndrome patients in real life. But the issue, as the step-by-step approach is advocated by ESC guidelines and also by American Association guidelines, it's difficult to cardiologists in clinical practice to choose which one is the better. But we know from several registries, especially from Sweden and from Norway, that an early implementation of the upfront strategy associating high-intensity statin ezetimibe before discharge is associated with a long-term benefits. Why? Because in clinical practice, you have few changes to intensify lipid-lowering treatment strategy. The main trend is to decrease statins dose and not to implement ezetimibe and PCSK9 inhibitor. We performed 2 recent national surveys online, and we saw that the implementation remains suboptimal, as ezetimibe is prescribed only in 15% of patients after acute coronary syndrome, and then PCSK9 inhibitor prescription represent 3% in the second survey, whereas in other registry, we know that about 10 to 15% of acute coronary syndrome patients may benefit from a PCSK9 inhibitor. That means that the LDL cholesterol at 1 month or 3 months or 6 months is above 70 milligram per deciliter under optimal maximal doses of statins and ezetimibe. The first point, there's a gap in knowledge about the efficacy of lipid-lowering treatments by cardiologists. I'm sorry to say that, but many cardiologists think that using high-intensity statins is needed and it's enough to reach the targets. And we know from Santorini study and other studies that it's not sufficient to reach the guidelines because the LDL goals are very low. It's below 55 milligram per deciliter, and it's clearly proven by 3 randomized clinical trials. But the issue that we use to prescribe 80 milligram of atorvastatin before discharge, but 80 milligram of atorvastatin before discharge is only a decrease by 50% of LDL cholesterol from baseline. So for many patients, you cannot reach the targets below 55 milligram per deciliter of LDL cholesterol. And it's proven in Santorini study, for example. So for this reason, we are several experts who advocate an early and intensive lipid-lowering treatment strategy using high-intensity statins. That means atorvastatin high doses or rosuvastatin high doses and ezetimibe before discharge. And at 1 month, you can prescribe PCSK9 inhibitor for patients who are above 70 milligram per deciliter of LDL cholesterol under maximal tolerated dose of statins and ezetimibe. But in practice, it's not used, it's not prescribed. The main issue also for cardiologists, I speak about cardiologists, is that they underestimate the benefits provided by lipid-lowering treatments. For example, using PCSK9 in Odyssey outcomes and in Fourier decreased by 30% the need of planned as well as urgent revascularizations in these two randomized clinical trials. But many cardiologists ignore this. So it's crucial to implement an early and intensive lipid-lowering treatment strategy, but many cardiologists are focused on dual antiplatelet therapy, which also provide benefits, but it's a combination of intensive dual antiplatelet therapy in short term with lipid-lowering treatments in combination using high-intensity statins and ezetimibe early before discharge for practical reasons, and adding PCSK9 inhibitor or inclisiran in countries which inclisiran is available for 10 to 50% of acute coronary syndrome patients. There is two major goals that I'm thinking. I try to repeat messages. The first goal is to better detect hypercholesterolemia, familial hypercholesterolemia, because you know that heterozygous familial hypercholesterolemia is very frequent. The prevalence is about 1 to every 300 patients, not patients, but individuals in the global population, whatever is the country. So it's a main challenge to better detect and early detect hypercholesterolemia in the global populations. So we need a better awareness by general practitioners, cardiologists, diabetologists, but also by the population. It's crucial that individuals will be aware of the crucial importance of an early detection of heterozygous familial hypercholesterolemia. That's the first thing, is primary prevention. The second challenge we have to face and to implement validated treatments. We have all the data about the benefits provided by an early and intense lipid-lowering treatment strategy. Despite this, we have shown and we have reported in several trials that the cardiologists should be aware of the benefits provided by an early and intensive lipid-lowering treatment strategy. And that's not the case despite repeated messages and despite the amount of proof. For example, you have data from Sweden and from Norway that to prescribe an intensive and early strategy using high-intensity statins and ezetimibe before discharge, and to intensify early the lipid-lowering treatment strategy provide long-term benefits because you have few changes to intensify the treatment, whereas the main trend is to decrease statins dosage. Thank you for your question. Interdisciplinary collaboration is key to improve knowledge between different specialties. So it's very crucial to promote this collaboration among experts and with different also generations, because it's great to work with the younger in order to improve the global knowledge. That's a positive trend. And so we should continue, for example, using social media allow to collaborate more with experts, but also with the younger. And we have a win-win collaboration because the younger are very energetic and they are very positive energy. So it's good to guide these young experts, and they can improve their knowledge by collaborating with us. So that's a great trend, and it's promoting by some social media also when you use this adequately. Thank you for the question. At this stage, it's a pleasure to be a mentor for the youngest, because the youngest are the future. They will care us when we will get older. So it's clearly important to lay the main messages, but we are convinced to improve cardiovascular disease. So as you know, I'm working with several younger the rising stars. I can call them rising stars. It's a pleasure to collaborate with them. They are like my spiritual sons, and we are working very well. And it's very interesting to collaborate with them, really with a young rising star. My key message is not to be clever. It's useful to be clever, but the most important thing is to be motivated and to be persistent. You should be consistent. I'm not very interested by the classifications of their studies, of their awards. I'm very interested by if they are highly motivated and if they are persistent in the project, because the project should be concluded in few times, in few months, and you need highly motivated fellows, whatever are their previous skills or previous results. What counts on me is to be now what you can perform, what you can provide, and not what you have done before. So be motivated and be consistent.